Hello guys, this is Dr. Asif. As the continuation of previous video, I'm going to make a new topics about the abdominal trauma. Previously you have seen a lecture about the thoracic trauma. Now I'm going to continue the next presentations about the abdominal injury. So here you can see a baby's chest wall along with some connections. Okay, so let's see. So as like the thoracic region, there are also abdominal portions. So you can see different kind of radio opacities. So what it shows here, the chest radiograph showing gunshot wound with the bullet markers. So the gunshot wounds with the bullet markers here, and the abdominal radiograph with the gunshot wound shows also the bullet markers here. So in the previous video we saw some conditions that is called deadly dozen, and now I'm going to start the today's presentation about the abdominal injuries or abdominal trauma as like. So here the patients who have suffered from abdominal trauma can generally be classified into the following categories based on their physiological conditions after initial resuscitation. So first initial resuscitation done, then the second part is the physiological classifications of injury. Hemodynamically normal, the investigations can be completed before treatment is planned. So normally hemodynamically normal patients, that is investigation can be completed before treatment is planned. Hemodynamically stable patients, so what it indicates, that investigation is more limited. So here in case of stable patients, investigation is not so necessary, but in case of normal hemodynamic patient, not stable but normal, investigation can be completed before treatment is planned. Okay, here. So let me a system. It is aimed at establishing whether the patient can be managed non-operatively, where the angioembolism or embolizations can be used to whether surgery is required. Sometimes in case of stable patients we need to manage non-operatively, okay, and angioembolizations can be used whether surgery is required, because there is a huge chances thromboembolic manifestations during surgery or after surgery in the post-operative period. So for prevention or reduction of the risk of thromboembolic complications, we need to prepare the patients for non-operatively if in the maximum period, but if surgery needed, then embolization must be done before surgery. In case of hemodynamically unstable patients, investigation need to be suspended as immediate surgical correction of the bleeding required, because there is no time for investigations. We need to go for direct surgery for stopping of bleeding. I hope so. Now the trauma laparotomy is a final step of pathway. That is final step of pathway is laparotomy. Occasionally it is difficult to determine the source of bleeding in the shocked and multiple injured patient. Sometimes it is difficult for whether in case of shocked patient, because we need time to find out the trauma or where the injury occurred. But if the patient is already in shock or hemodynamically unstable, in that case the source of bleeding must be find out by laparotomy. There is no other way. If doubt still exists, especially in the presence of other injuries, like a laparotomy may still be safest option. So laparotomy is the option. If you are confused about abdominal injury or blunt trauma abdomen, in this case go for laparotomy, because there is no other way. because by doing this you will find out the bleeding point. Also you can find out the other organs that might be affected with the trauma. The patient's physiology must be assessed at regular intervals. If there is an indications that the patient is still be actively bleeding, then source must be identified unless the patient is unstable. Okay, and require immediate surgery. Blood loss into the abdomen can be subtle and there may be no clear clinical signs. If that bleeding can be ghost-like, like blood loss in the abdomen can be subtle or ghost-like, there may be no clear clinical significance. Sometimes some patients are deteriorating on table or in the ward. Blood is not an irritant but does not initially cause any abdominal pain, because blood is not irritant substance and does not clinically cause any pain. So it may be mimic with the fluids like ascitic manifestation, but there is no any irritation, because blood is already sterile. We know the blood is the sterile fluid of our body. So peritoneum will be irritated when there is a presence of irritating substance or irritating fluid like gastric fluid, like the pus or other fluids or infected fluids. But blood, as the blood is sterile, there will be no irritation. So distension is a subjective and drop in the blood pressure may be very late sign. So distension is subjective. The patient will say that his or her abdomen is distended, and a drop of blood pressure may be very late sign. Okay, so when blood pressure falls or hypotension, that means the patient is in shock. Okay, examination in the unstable patient should be take care of the ED, that is emergency department, in the operating theater if the patient is dead rapidly. There is no time there is no time for examinations, but if you want to do this, in that case must do it in the laparoscopy table or operating theater or emergency department, where there is a chances to do laparoscopy immediately. So what kind of investigations? So as we all know that we all already studied that minimum investigation must be done within a short time. So CT scan is the choice, most sensitive modalities of chest. In the patient with the penetrating injuries like metal markers, bent paper clips should be placed on the external wound before plain films are taken, irrespective of the area being radiographed, as this allows an assessment of the trajectory and helps to correlate the number of holes and the number of missiles that can be seen within the patient. So here in the gunshot wounds, you can see that a plain radiograph may show some radio opacities, or the CT scan is the sensitive test. This will help determine whether two holes are negative. Okay, now the next part is a fast scan, that is focused abdominal sonar for trauma and extended. This is the fast scan. So fast scan is sonographic techniques, FAST, which is used to assess the thoughts on the presence of free fluid. It will be positive when there is a free fluid in the abdomen and the thoracic cavities. There should not or no attempt to determine the nature of extent the specific injury. EFAST is usually rapid, reproducible and portable, and non-invasive bedside test can be performed at the same time as necessary. EFAST is accurate at detecting more than 100 ml of free blood. However, it is very operator dependent, and especially if the patient is very obese or bowel is full of gas, it is maybe unreliable. So EFAST is not the gold standard examinations or investigation, but if there is a free fluid or blood more than 100 ml or fluid more than 100 ml, in that case it will be positive. So it may become to the MCQ exam, that is how much fluid must be present in the abdomen to be positive in EFAST scanning system, that is ultrasound system. EFAST is low sensitivity, 29 to 35%, so sensitivity is not so good for organ injury without hemoperitoneum. So without blood in the abdomen, there will be low sensitivity of the EFAST. Also unreliable for excluding the injury penetrating trauma. In case of penetrating trauma, it is this investigation has no use. If there is doubt, EFAST examination can be repeated. So repeatedly we can do this kind of investigations. Now the utilization. Detection of free fluid in the abdomen or pericardium will not reliable detect less than 100 ml of free blood. Less than 100 ml, it is no use. Does not directly identify injury to hollow viscus. Cannot reliably exclude injury in the penetrating trauma. May need repeating or supplementing the other investigations. So with the EFAST, we need other investigations. Is unreliable for assessment of the retroperitoneum. So in case of retroperitoneal injury, it is unreliable. So there will be no use in retroperitoneal injury or penetrating injury or the fluid less than 100 ml in the abdomen. In these three things, there is no use of EFAST. We need to go to the CT or the other modalities of treatment. Now the diagnostics peritoneal lavage is a test used to assess the presence of blood or contaminants in the abdomen. A gastric tube is placed to empty the stomach and the urinary catheter is inserted in the blood. So these are the lavages system: peritoneal lavage or gastric lavage, colonic lavage. Lavage means the washing of the organs. Okay. So cannula is inserted below the umbilicus. So this is the procedure by how you will make the lavage. So 1000 ml of warmed ringers lactation is allowed to run in the abdomen and then dry it out by the same route. So first we will go through a catheters and then ringers, that warmed ringers, that Hartmann solutions must be inserted in the abdomen. Then by the same line, the whole fluid will be rebagged, and that is called the lavage system. So the presence of more than 1 lakh red cells, more than 500 fibroids is deemed positive. So this is the indications of interpretations of investigations. If the presence of vegetable fiber in the or the raised amylase level, that means the patient with pancreatitis or the patient with perforation of the gas containing hollow viscus. If that occurs, then vegetable fibers come with the peritoneum. Or if pancreatitis occurs in case of raised amylase level, in the pancreatic trauma, a minimum of the 1/10 of above would be regarded evidence of peritoneal perforation, penetration or interpetal injury. The absence of laboratory findings and the urinary diptychs may be useful. In the absence of laboratory findings, if there is a lack of laboratory facilities, a urine dipstick test may be done, and drainage of lavage fluid via the chest indicates penetration of the diaphragm. So if fluid comes to the chest drain, abdominal fluid, the abdominal fluid to the chest drain, then it is regarded as there is a diaphragm injury, by which the abdominal fluid come easily to the chest, and then the fluid comes to the chest drain. So diagnostic peritoneal lavage has already been replaced by EFAST. So nowadays diagnostic peritoneal lavage is not done. In that case, EFAST is an alternative. So especially use a full hypotensive multiple injuries that may excluding the intra-abdominal bleeding. Now the laparoscopy. So there is we know that laparoscopy is a minimal invasive techniques. So there are two kinds of laparoscopic approach. One is diagnostic, another one is therapeutic. So we only first in the first decades of invention of laparoscopy, everybody or the doctors are using the laparoscopy as a diagnostic purpose. There is no therapeutic approaches, but nowadays therapeutic approaches is more or widespread in the worldwide, that laparoscopy is now used not only for diagnostic purpose but also in the therapeutic one. So sorry to say there is another files come here. So okay, so here the laparoscopy screening, diagnostic and therapy. There is three kind of. Another one is screening, used to exclude a penetrating injury with breach of the peritoneum. Okay, screening, that is we can see the whole peritoneum, and diagnostic is finding evidence of injury to the viscera, and the therapeutic is used to repair the injury. That is, nowadays is the modern world of therapeutic laparoscopy. In the most institution, evidence of penetrating injuries in laparoscopy evaluate organ injury. It is difficult to exclude all interabdominal injury laparoscopically. When used in this whole role laparoscopy is non-therapeutic laparotomy. There is no place for laparoscopy in the unstable patient. So in case of unstable patient, we must not do the laparoscopy because we have a less period of time for survival. Now the individual organ injuries. The blunt liver trauma occurs as a result of direct trauma. So the liver is usually compressed between the impacting object, the rib cage, and vertebral column. So another one is a blunt trauma liver. The liver is a solid organs, the compressive force. Okay. So that is all we know, that the most injuries are relatively minor, can be managed non-operatively. So maximum liver trauma is managed non-operatively. Either there is a chances of continuous bleeding or major rupture of the any hepatic vessels. Penetrating trauma to the liver is all relatively common. The bullets have shockwave, and when they pass through the solid structure, the liver may cause significant damage some distance and actual tract of the bullet. Not all the penetrating wounds require operative management and may stop bleeding spontaneously. In the stable patient, CT is investigation of choice. So in case of liver trauma, if the teachers ask the students what is the prime investigations that you can know the liver is traumatized, in that case the gold standard examination is the CT scan. It provides information on the liver injury itself as well as on injury to the adjoining major vascular biliary structures. So not only trauma, it also show us the adjoining major vascular or the biliary structures. So here you can see liver is traumatized, but the managed operatively. Injury is there is a suggestion of vascular components should be re-imaged, as there is significant risk for development of ischemia, false aneurysm, and atrioventricular fistula or hemobiliary fistula. So these are the complications after the liver trauma. Now what can be done operatively? So if I can see the massive bleeding coming from the liver vessels or liver, then first we have to block the supply of the liver, that is portal triad, that is hepatic artery, portal vein, and the hepatic duct. That is three structures. Portal triad it is also called. So we must block that by which Pringle's maneuver. So here is the Pringle's maneuver. You can see here this is blocking the three vital structures. This is called the Pringle maneuvers. So you must know the mechanism here, because by which 80% supply come from the portal vein must be blocked. In that case, chances of bleeding will also reduce. So push, Pringle, plug, and pack. So this is the management plan or principles of management. These 3-4 system: push, Pringle, plug, and pack. At laparotomy, the liver is reconstructed and bleeding is controlled by direct manual compressions. That is, by both hands I can pack up the vessels. Then another one is a push. I can push or pressurized by my hands. The inflow and portal triad is controlled by Pringle maneuvers. I also said this is effect to reduce arterial and portal venous flow to the liver, although it does not control backflow from intravenous, inferior vena cava, and hepatic veins. Any holes due to penetrating injury can be plugged directly using silicone tubing and Sentegan Blackmore tube. So this is a special kind of tube, Senten and a plug and pack. This is the maneuvers or principal practice of surgery. And the hepatic artery can be tied off, but not the portal vein, which should be stented, because portal vein is the 80% supply of the liver. If we ligate the portal vein, then the liver will not get adequate blood. In that case, liver will be ischemic changes. So we will bind the hepatic artery to block the 20% bleeding, but not the portal vein. Then the suction drainage is used. Now the biliary injuries, the common bile duct can be repaired with the T-tube and drained. So after biliary injury repair, T-tube is inserted. That you all know that. The splenic injury occurs in direct blunt trauma. Most isolated splenic injuries. Isolated. Especially in children can be damaged non-operatively. However, in adult, especially in the presence of other injuries or physiological instability, laparotomy should be considered. However, the adult special present injury physiologically or instability. If a patient with blunt trauma abdomen and hemodynamically unstable, so it is regarded most commonly injured part is the spleen. So laparotomy is the only choice. Now splenectomy is a safer option. First, spleen must be packed and repaired in the mesh bag. If we first we will try to compact or packed or repaired the mesh. First we will use a compact mesh. If we fail, in that case splenectomy is the safe option, especially in the unstable patient with the multiple potential sites of bleeding. If unstable patients, in certain situations selectively angioembolization of the spleen can play a role. So angioembolization techniques is as the another techniques of controlling the bleeding. Following splenectomy, there are significant transient changes to blood physiology. The platelet white count may be raised. Inoculation of the pneumococcus within the 2 to 3 weeks, each time of patient's immune system is recovered. Okay. Now the other organs in the abdomen, that is first, the another one is spleen. Most splenic injury occurs as a result of blunt trauma. The major problem is the diagnosis, because the patient is retroperitoneal, so CT scan is the mainstay of diagnosis. Classically, the patient pancreas should be treated with conservative surgery and closed suction drains. Injuries to the pancreatic body to the left of the superior mesenteric vessels and the tail are treated by the closed suction drainage alone. Distal pancreatomy is a duct is involved. Okay. If we do distal pancreatomy, then duct is involved, and the superior mesenteric artery sometimes it is also injured. And they treated conservatively as possible. Proximal injuries are treated conservatively. Partial pancreatectomy may be necessary, although tarporeo, whatever it says, partial pancreatectomy is necessary. A Whipple's procedure, that a pancreaticoduodenectomy is rarely needed and should not be performed in the emergency situation because of the high associated mortality rate. So Whipple's procedure is not done in the emergency situation. It will increase the mortality rate. Now the stomach. Most stomach injuries are caused by penetrating trauma. Blood presence in the diagnosis is found in the nasogastric tube, and the absence of bleeding is other causes. Surgical repair is required, and the great care must be taken to examine the stomach fully, as injury to the in front of the stomach can be expected to have an exit wound, whereas on the organs. Now the duodenums. The fourth important organs. Duodenal injuries frequently associated with the injuries to the adjoining pancreas. So if there is injury to the pancreas, so we must look out the duodenum also, because duodenum or the second part, moreover the full duodenums or maximum part of the duodenum is attached with the head of the pancreas. We all know anatomically. In that case, there is also a chances of duodenal injury. Like the pancreas, duodenum lies retroperitoneal also, so injuries are hidden, undiscovered late or undiscovered at the laparotomy performed by other physicians. CT is the diagnostic choice. Here also CT scan is mandatory. The only sign may be gas or fluid collections in the periduodenal fluid. So periduodenal tissues, there you can see some fluids, and the leakage of oral contrast. When we will because to know the points, we must done some contrast imaging X-ray. If we see that imaging contrast will come to the peritoneum, it is also a sign of injury. The first, third and fourth part of the duodenum behave like small bowel and can be repaired in the same fashion. Okay, not the second part, first, third and fourth. Second part of the duodenum is fixed to be head of the pancreas with the common blood supply, may have a poorer blood supply compared to the remainder others. In comparison to the other part of the duodenum, second part is poorly infused. Major trauma, especially if the head of the pancreas is stomachal injury, should be treated as a part of damage control procedures and referred to the definitive cares. Now the small bowel. The high pressure rupture of the loop or tearing of the mesentery. The individual loops may be trapped. So loops of the intestine is trapped and the high pressure occurs and rupture of the loop. Penetrating trauma is also the common injury. So common injury also, that is called the penetrating trauma or stab injury. Small bowel injuries need urgent repair. Hemorrhage control takes place priority, and these wounds can be temporarily controlled with and the loop colostomy, or pre-sacral drainage is no longer used. Then the renal urological tract injuries. In the stable patient, CT scan is the best choice, and minimum 300 ml of contrast is instilled into the bladder via the urethral catheter. So we will use 300 ml of contrast to detect the rupture point or injured portion of the bladder. Two views, AP view and lateral view, and the two occasions, full or post micturational. So there are two times when we perform CT or X-ray, so that is two full or post micturations, and two views, that is anteroposterior and lateral views. Interperitoneal rupture of bladder, usually from direct blunt injury, will require surgical repairs. Surgery is mandatory. Extraperitoneal rupture is usually associated with fracture of the pelvis, will heal with adequate urine drainage via the transurethral route. So here the whole summary of the abdominal injury. In children, splenic injury may be managed non-operatively, okay, but not if the hemodynamically unstable. If unstable hemodynamically, then splenectomy is done. Duodenal injuries are often associated with penetrating trauma. Bowel injury may need urgent definitive repair, isolated using resection by stapling or stapling devices, and that is stapling devices is used for resection anastomosis by side to side or end to end anastomosis. Rectal injuries may be best managed initially diverting the colostomy. So colostomy is the emergency settings management. And the kidney is best managed by the enhanced CT scanning, and internal bladder tear need to be formal repair and drainage occurs. So now the retroperitoneum. So there are three zones: central zone, lateral zone, and the pelvic zone. So in three parts, what kind of injury is occurs? Central hematomas should be always explored, and the lateral hematomas should only be explored in the expanding pulsatile. Zone 3, they should not be explored in the expanding pulsatile pelvic hematomas. Expansion difficult to control, when possible should not be opened. Now the pelvis. Okay, pelvis, the mortality rates exceeding 40% recently been reported. Further, pelvic bleeding as one of the hidden bleeding sources is still underestimated and missed. And retrospective chart analysis of the potentially preventable death have verified. Now, hemodynamically unstable patient with severe pelvic fracture has a 90% risk of associated with injuries or 30% intra-abdominal bleeding. So it is a huge risk or threatening conditions. To save these patients, three questions will be needed. Is the patient is a high risk of massive bleeding? Where is the source of bleeding? How to stop the bleeding? So these three things, the three questions must be arise to the physicians or the surgeons. So you see the anatomy, you all know the anatomical inlet and outlet, and so these are the patterns of fractures. So where pelvic fractures occurs? Here, these kind of fractures. Now, inspection of the skin may reveal laceration of groin, perineum, and sacrality, indicating a pelvic fractures. So, we can see clinically how possibility of pelvic fractures. And the inspection of the urethral meatus may reveal a drop of blood, indicating urethral damage. So, what is the lateral compression, pelvic collapse, and open book fracture is seen in the widening of the pelvic symphysis and widening of the set of fracture of the pelvic ramus. So they are the pattern of investigation or interpretation of the X-ray. So it will be read out through thoroughly and also see these kind of things. The pelvic injury summary, very important. So the patients with deadly triad, the hypothermia, acidosis, and coagulopathy, these three things very dangerous. The deadly triad, and that is highest risk. Damage control, damage limitation surgery is concept that originated from naval shipbuilding strategy, whereby ships are designed so that the damage can be kept local, which allows only the minimal repairs needed to prevent it from sinking, while definitive repairs waited until it has reached port. The minimum amount of surgery needed to stabilize the patient's conditions may be safest course until the physiological derangement can be corrected. Damage control surgery is restricted to only two goals: so stopping any active surgical bleeding, controlling any contamination. So two things we must remember, two things. One is a stopping of any bleeding points and the controlling of contamination. So this is the two unique principles. So indication of damage control surgery, by C here, the temperature must less than 34, pH less than 7.2, lactate more than 5, prothrombin more than 16 seconds, partial thermoplacent time more than 60 seconds, more than 10 units of blood transfused, and environmental operating time is more than 60 minutes. If there occurs core temperature loss, usually 2 degrees centigrade. So we must hurry the operations if we need. So diagram showing temporary skin closure damage control. Okay. So what is the stagings? Patient selection, control of hemorrhage and control contamination, deceleration will continue in the intensive care unit, definitive surgery and abdominal close. So now this is the important physiological table, that is in the renal system what occurs in case of pelvic fracture or any kind of fractures. Increased renal vascular resistance leading to glomerular filtration rate is reduced, impaired renal functions. Another one is a decrease in venous return resulting in decreased cardiac output, that is a cardiac decrease because both a reduction of preload and afterload and increase of the afterload. Respiratory ventilation pressure is spleening of the diaphragm, decrease lung compliance and increase the airway pressure. Lung compliance will be reduced and airway pressure will be increased, and rise intracranial pressure as well. So damage control surgery is carried out in the operating room using biologically active fluid like blood. So damage control, in case of damage control part, the maximum fluid or resuscitation with the fluid is done by blood, and the surgery performed the minimum needed to stabilize the patient. The aim of surgery are to control hemorrhage and limit the contamination. That I already said there. Here stopping of the active bleeding and controlling the contamination. Abdominal compartment syndrome and open abdomen, very important. Very important. Raised intracranial pressure, far-reaching consent of patient syndrome that is known as the abdominal compartment syndrome. More than 30 or 28 to 30 millimeter of mercury pressure will be arised in the abdominal compartment. In that case, blood vessels will be compromised. So immediate postoperative phase is considered risk. Abdomen should be left open and managed as a damage control surgery. Our interventional radiology can be useful in management of the torso trauma if both investigation and therapeutic tools, the patient is a vascular injury and embolism. Following demonstration of the ongoing bleeding in splenic and renal injury is valuable techniques. Now non-operative management. Non-operative management is generally preferred for the management of solid organ injury like hematodermal, a stable patient. Stable